Yeah, thank you for introduction. I'm preparing a very short, very brief introduction of this study compared to previous presenter. My study is about the venous outflow ratio measured by Synapse software in living donor liver transplantation using right lobe graft, especially focusing on the importance of inferior right hepatic vein. Nothing to disclose. There has been increasing needs of living donor liver transplantation under worldwide ongoing severe organ shortage. Living donor liver transplantation consists of over 75% of total liver transplantation performed in Korea. LDLT provide a very excellent outcome as about from 75 to even up to 90% of 5-year graft survival. In LDLT, anatomy of partial liver graft is very important factor for both sides of donor and recipient surgery. Among various kind of liver graft, modified right lobe liver graft is most popular, even though there is regional variation. Modified right lobe liver graft can provide can prevent the congestion of both sides of graft and remnant liver of donor by reconstruction of middle hepatic vein branch. Sometimes we encounter a right inferior hepatic vein. The more than 5 millimeter size is considered as considerable right inferior hepatic vein, and the frequency has reported up to 40% of right liver rope graft. In 15 to 20% of cases, there is multiple considerable right inferior hepatic vein. Reconstruction of right inferior hepatic vein could be done by direct anastomosis to IVC in most cases, but especially for multiple right inferior hepatic vein, we can use venoplasty or autolose or sometimes artificial vessel conduit to make easier the anastomosis and the better patency. There has not many reports about the importance of right inferior hepatic vein, but few studies reported that right inferior hepatic vein provide better long-term patency than reconstructed middle hepatic vein, so it has benefit for venous outflow. I'd like to introduce our recent previous study in press. The title was Anatomical Complexity of the Right Lobe Grafts. We defined from the single center study, we defined the complex graft when it has at least one of multiple hepatic artery and portal vein or right inferior hepatic vein or bile duct. The conclusion was very simple. The complex graft has, there was no survival difference between the complex graft and control graft. But there was one interesting finding of our study. It was that when the right lobe graft has multiple right inferior hepatic vein, it shows better graft survivor than that with less than one right inferior hepatic vein, even in the matched analysis. So this finding made us plan to investigate more about the importance of right inferior hepatic vein. So the study aim was to investigate the correlation between the outflow ratio via right inferior hepatic vein and long-term graft outcome. We are using about 900 eligible LDLT patients using right lobe graft. We are measuring various venous territory using Synapse software. The components would be portal vein inflow volume and right inferior hepatic vein, right hepatic vein and right inferior hepatic vein and middle hepatic vein territory. This picture is one example of actual measurement by Synapse software, which has multiple right inferior hepatic vein. So we are analyzing the impact of venous outflow factors such as various various hepatic venous outflow territory and calculated the various ratio and diameter and multiplicity of right perihepatic vein on long-term graft survivor of right LDLT. So we are expecting our result would provide good additive information for living donor selection. Thank you for your attention.